challenging to keep up with everything, and though is leading to new treatments and better care of lung cancer though for our patients. So again, I just want to echo Paige's thanks to our sponsors. It's really amazing to have such wonderful support for LCI for this programming and for our patients from these companies. And so again, just a big thank you to all of the sponsors listed here, again, for supporting everything. So for those of you who are not as familiar with LCI or new to interacting with LCI, I personally think we are incredibly fortunate in North Carolina and the Carolinas more broadly to have an organization like LCI supporting us as providers and far more importantly, our patients and families. But this is the mission for LCI. So to advance the survivorship and provide support for those affected by lung cancer through research, education, and access programs. And there are numerous examples of how LCI accomplishes each of these. And for me personally, it's been a really inspiring organization to be a part of. And I would encourage you, if you're on the meeting tonight, if you're new to interacting with LCI, to find a way to be involved. All right. So a little bit further on that note, LCI provides a number of different things specifically for providers and again, more importantly, patients, free educational material, gas cards, which is incredibly important for many of our patients who have to travel distances for their cancer care. Obviously, research funding, community education, provider education like we're doing here tonight, and then really amazing events, survivor engagement events, events like 5K runs, golf tournaments, galas that allow us to generate hope, inspire others, be inspired by the patients who we are here to serve. So on that note, our annual Lunge Forward race will occur next month throughout the state and in South Carolina. This is going to look a bit different this year, obviously. This is a very important event that helps us create hope and help fund the critical mission of LCI. There are a lot of people working very hard to make sure that this event is as safe as possible and is keeping everyone again as safe as possible. For full details, go to lungeforward.org to find out more and how you can participate. Please spread the word. Okay, so I don't know about everyone else, but I may have been watching too much Star Wars or Mandalorian with my 6-year-old during the pandemic, but I feel like lung cancer, particularly in the past 12 months, is moving like this at warp speed. And we have more drugs approved than ever. And we are seeing the survival curves actually move year to year. And as we improve the survival of our patients and improve the lives of our patients and their families with the exciting treatments and developments that have that are coming out. So to dive into this a little bit more, we'll be hearing some about this this evening, but we've known for well over a decade now that if we pick the right drug and match it to the right mutation in the right patient, we can stop lung cancer in its tracks and improve survival, improve quality of life, and really benefit our patients. We know that lung cancer is a very molecularly heterogeneous tumor, one of the most heterogeneous tumors in my opinion. And we see that this kind of pie chart here, these slices of the pie are increasing and we're identifying new targets, new actionable targets, and developing new standard treatments to go with those. And I think it's a really exciting time to treat lung cancer and to again, treat our patients. This is a chart that I made about a year ago And it's incredible how out of date this was almost immediately. And in fact, when you look at it today, there are no less than 6 targeted therapy approvals in this landscape for our patients, which is really incredible, including our first adjuvant therapy, our first KRAS therapy, and so really incredible developments, I think, in the past year, and accomplishments for the field. This is in addition to multiple FDA approvals for new combinations with immunotherapy as well. But so to quote my favorite Hamilton character, what comes next, right? So we've come this far and we've seen all these changes in the past year. What is coming next? What's over the horizon? And I think that we're going to hear about some of these tonight. There's been some really exciting data that's been presented this year, specifically around perioperative management. How can we improve outcomes with immune therapy perioperatively? How can we use targeted agents perioperatively? I mentioned the first adjuvant targeted therapy that was approved. How can we improve surveillance or measuring residual disease in our patients using ctDNA? I think we always have room to further exploit mechanisms of resistance, particularly with these targeted therapies. We have seen really exciting data with novel IO combinations like TIGIT and LAG-3, for instance, which I hope are going to further change the landscape of lung cancer moving forward. But I think that, I think as we'll probably hear tonight, we need to start with things that are fundamental, like simple genetic testing for our patients, and making sure that, again, we can come back to picking the right drug for the right mutation and pair that with the right patient. So with that said, it is my honor and pleasure to introduce tonight's speakers. These are the, going back to the Star Wars reference, maybe the Jedi Knights, I think, of lung cancer care in North Carolina. So Dr. Daniel Hagstrom from Levine Cancer Center, Dr. Jimmy Ruiz from Wake Forest Baptist Health Center, Dr. Chad Pico from UNC, Dr. Andrea Oliver from ECU Heart Institute, and Dr. Haran Mehta from UNC Rex. So this is the outline for tonight's talks. We'll hand things off to Dr. Mehta right now to talk to us about updates in lung cancer screening and respiratory issues related to lung cancer. Dr. Mehta.
Yep, let me share my screen here. I think, yeah, there we go. All right, you got that? Is it showing up on there? All right, perfect. So I realized that I had 15 minutes after I did this presentation, so I will try to cut some of it out and go quickly through some of it. Really, the big exciting stuff is the new updates, which I'll cover towards the end and try to get all of it in. But I wanted to take you through a bit of a timeline for lung cancer screening. A lot of you are involved in lung cancer screening. There's been a lot of questions about insurance coverages, the new guidelines, all that. I hope to cover some of that today. Really, I just want everybody, once you leave here, I want you to be able to recognize the recommendations for lung cancer screening, kind of know the background literature, where these recommendations come from, and it shapes the criteria that we use with patients. A lot of you guys know and are involved in lung cancer and know it's a serious problem. We know that it kills just a terrible amount of people every year. 158,000 people die of lung cancer. That's a 747 plane full of people die every day from lung cancer. It is something to be reckoned with. When you're looking at screening tests, any good screening test, really, there are a few things you really want in terms of a good screening test. You want people to live, so you want an overall good cure rate. You wanted better limited surgical resection options, and improved mortality and reduced morbidity. That's kind of the classic triad of things you want to see in a good screening test. And as we go through this, I'll go over the evidence of how lung cancer screening came about, this is actually pretty exciting. It's really mostly 10 years in the making here that we really started screening patients. And it's not because lack of trying, dating back to years ago, 60s, 70s, we were using screening options, what we had back then, chest x-rays, sputum samples, several studies, which I won't go into details of, utilize some of these tools to see if they would have been useful in screening. A lot of the times these showed no mortality benefit and weren't useful. And it wasn't really until the refinement of the CT scanner that we really saw a new kind of effective tool for lung cancer screening. It was the low dose CT. It really kind of revolutionized how we think of testing and radiation when it comes to lung. Here, what you see is the left hand, two pictures side to side, routine CT on the left, and then the low dose on the right. But you see the right side has a fraction of the dose of radiation, but effectively can identify nodules for a tenth of the dose of radiation. And that was until really when they refined this, when we realized that you can safely use CT imaging to identify nodules of very small sizes. It was once we figured out using a low dose CT is very possible, we really started going at it and trying to identify if this would really be what we were looking at. And we did do several studies over the years using the low dose CT. Unfortunately, a lot of the times it showed no significant mortality benefit, but a lot of the studies were underpowered. It wasn't really until the NLST trial that we really started seeing the mortality benefit to screening. And a lot of you have already seen this, and I won't belabor it, but it was the National Lung Screening Trial research that really got everyone's eyes and talking about screening. It's a multi-center study, looked at 53,000 individuals. And this is where the inclusion criteria is important, because you'll start seeing where it starts shaping our criteria for lung cancer screening. And it used 55 to 74-year-old age group, history of 30-pack years smoking, and active smoker or have quit within 15 years as their inclusion criteria. What they did was they split the two groups into a low dose CT group and then a chest x-ray group. Remember, we used to use chest x-rays before. This would have to test against that. And it did. It showed significant reduction. 20% fewer lung cancer deaths were noticed in this trial with the CT group when compared to the chest x-ray group. So this was one of the first studies of its kind that showed a mortality benefit. So there was a 20% reduction in mortality with this study. What does that mean? So whenever you're looking at a screening test, you're looking at number needed to screen to save one cancer death. And you can see with lung cancer screening that number was set low. It was 320 with this trial. And to put that in perspective, mammograms is anywhere between 900 and 1900 to be screened to save one cancer death, and 500 with colonoscopies. So you could see that this already set the precedence that screening for lung cancer could be very useful. It was then there was a second trial, the Nelson trial. This is one to remember. This was a European trial. Really, it showed what it did was looked at 15,000 people. The age group here was different. There was 50 to 74, and that's important to remember. And I'll tell you that a little bit later why that number was important. But they randomized a group 1-to-1, and what they did was they split the group between a low-dose CT screening group, and no screening at all. And this was interesting because some of the highlights out of this showed a great compliance to screening. They had 86% CT screening compliance. They were able to identify 261 lung cancers. This was very interesting. 69% of those lung cancers were identified as early stage 1A or 1B. And that's incredible because before this trial came out, we were looking at the reverse, which is around greater than 70% would be identified as late stage lung cancer by the time we identified it. So this was an incredible find here. And it did reduce risk of lung cancer by 26%. So NLST was 20%. Nelson showed a 26% reduction in mortality. A big portion of that was also noted in women who derived a greater benefit from it. And you could see here that the surgical resection rate went up just because you're finding more cancers in early stages. So this was when the first set of recommendations from the U.S. Preventive Service Task Force came about. The 2013 recommendations came out. And what it said was screening any group between ages of 55 to 80, 30 pack year smoking, and this was the original criteria set aside from these studies, and who are either an active smoker or have quit within 15 years. This is a B recommendation. That's when we started screening. We got approval from insurance companies, and we started screening for lung cancer. Just wanted to go over the 30 pack year just to make sure everybody in the group is okay with calculating this. 30 pack year, it's just simple. You take the pack times the years, and then you get your 30 packs. If you smoke a 1 pack a day times 30 years, you get 30 packs. 2 packs per day for 15 years, you would get 30 packs, and so forth. So this is the new update that I really wanted to make sure I covered and went over with everybody. So recently, the United States Preventive Task Force came up with a new set of criteria to update the 2013 criteria. This was based on just a robust literature search, multiple publications, randomized controlled trials to come up with these new recommendations. But you'll recognize, and the new recommendations right here, including now, dropping the age to 50 from 55. You see, it was 55 to 80. Now they are recommending ages 50 to 80. And they also lowered the pack year from 30 to 20. And then the other requirements are the same, which is an active smoker or less than quit less than 15 years. So we reduced the age and the pack year. So what was that based on? And that's why I pointed out with the Nelson trial, they enrolled ages 50 to 74. Well, a fourth of those people fit into between 50 and 55. So we saw a 26% reduction also in that age group. And using that empirical data, they were able to say, well, when we were looking at ages 50, we were seeing a mortality benefit. And that was one of the reasons they came up with age 50 as should be the cutoff. The other requirements, which is, why the 20 pack year smoking, why are we lowering that? And even the younger age, this is based on multiple trials, looking at multiple studies based on lung cancer and ethnic groups and racial differences. This was one published in New England Journal that looked at, it just took a ton of cigarette smokers and looked at the risk of lung cancer. And it showed that there was a significant risk of lung cancer earlier in certain minority groups than when compared to whites. And that included African Americans, Native Hawaiians, and Latinos. And so this was one of the studies they used as background of lowering the actual age group, but also the amount of smoking. A similar study looked at a community of cohort study, looked at 48,000 people. When they went back and looked at the data and said how many of these would have been black, would have been screened versus white, and it was significant, it was almost half. Half of the people would have been screened based on the 2013 USPSTF guidelines if you were a Black American versus a white American. And similarly, they looked at it after you got a diagnosis of lung cancer, looking back and saying how many of those would have been screened before they got this diagnosis. And it was a lower rate in the African-American group versus the white group. And then also similarly, they looked at age, and the African-American age group was younger at stage 4 lung cancer than the white American. And so you started seeing this trend of finding lung cancer earlier would be helpful in certain minority groups. So again, here's a background, just a breakdown of the differences. We're dropping the age to 50, and then the 30 pack year goes down to 20 pack year. So this was largely, this was from the literature we talked about. This change was to help identify and encompass a missed underrepresented population. This change, as subtle as it is, would essentially increase those eligible for screening by 87%. And you'll see here with the percentages, a lot of the minorities and underrepresented would be included in the new screening guidelines, and that was one of the points that they made. And this would also see a notable difference and improvement for women being screened as well at a younger age and a less smoking history. You know, you can't talk about all the positives without the negatives. I think we've all, as providers, seen some of the negatives, false positives. Remember, a large portion of the nodules and the abnormalities we're going to identify in these are not cancer. And so this does create some great anxiety for our patients. I myself really go over this with my patients when I'm ordering a lung cancer screening, trying to help them understand to keep this in perspective. You will also see the opposite, which is false negatives. Not a negative screen doesn't mean you don't have lung cancer. We talked about the radiation exposure and obviously the cost sometimes to patients, whether it be copay or not covered at all by insurance companies, which I'm sure some of you are seeing now. I just threw this in here, you know, and I just for time's sake, I'll just go through it. But I was gonna quiz you guys to see what's the overall a screening rate for North Carolina. I was supposed to say 60%, but really in North Carolina we're at 6%. That's terrible in terms of how many people should be screened and that we're screening. We're at 6%. Nationally, it's only 4.2%, and that's based on the old criteria, 2013 criteria. So more people will be eligible for screening, and this percentage will even be lower. To put that in perspective, those getting screened for colorectal cancer around 67%. And for mammograms, for breast cancer screening is around 73%. So we have a lot of work to do with lung cancer screening. And that's why it's important we know the guidelines and we bring it up at every one of our encounters, no matter what specialty we're in. You know, Dr. Clark mentioned we're starting to see a stage shift, you know, with treatment and with lung cancer screening. And this is the exciting part. You know, we've always historically seen mortality benefits or mortality, 5-year survivals abysmal in 3 to 5%, depending on where you look. But there's a lot of literature showing that with screening, you can see survival benefits of 85+%. And that's why it's important for us to really start screening our patients and having this conversation. I put this on here. I won't go into too much detail for time's sake. Hopefully you guys will have these slides. This is mostly for the coverage. There's always been a lot of questions on, are we going to cover the new guidelines? You know, it took several years for insurers to start covering even the 2013 guidelines once the task force had put up the criteria. In my personal practice, and I think most notably, I think private insurers are covering and going off the new guidelines. Medicare, Medicaid, not so much. It may require a phone call or approval, but I just put this in here for you guys to look at. But keep in mind when you're having it, you have to have an encounter with a patient when you're talking about lung cancer screening. So they call that shared decision making, whether it's a face-to-face or a phone visit. You really have to have that discussion about the pros and cons of screening, like we talked about. Some of the symptoms of lung cancer, recognizing those, and maybe choosing a different modality of testing rather than a low-dose lung cancer screening, which is usually used in asymptomatic patients, and then really knowing the criteria. Quick summary, remember NLST showed 20% reduction, Nelson 26% reduction in mortality. Lung cancer screening CTs are safe. You saw the radiation dose is a fraction. The guidelines have changed. It's up to us to recognize that and really utilize that. And we just need to continue to educate ourselves, educate our patients, knowing that we're still very low in terms of screening in North Carolina. That's all I got. Look at that, 16 minutes, not bad at all.
I think I might be up next. I'm not sure.
Yeah, Dr. Oliver, if you want to jump in, that would be great.
Yep.
Let's see. Let's see if you guys can see my screen. I think I have an older version of that. And hopefully you won't get, you will get this. Let's see if I can turn off my subtitles. All right, that's better. Okay, mine is blank, probably because I'm a surgeon, and so everything's going to be in black and white, and it's going to be extremely low budget. But it also is going to be really quick. I really try to stay in a discussion about the surgical perspective of early stage lung cancer. And that's actually something that, you know, it's kind of like the holy grail for us as surgeons to have somebody who's a stage 1, because it's really one of the rare moments in my practice where we get a chance at cure. And just to kind of echo Dr. Mehta's talk, it really is about being educated. It really is about every one of us being active and knowing how to catch things early. And then where do we go with that information? It's always a multidisciplinary conversation with our patients. It's always having all the players at the table. And that's how our patients get the best outcomes, make the best decisions about what makes sense for each individual, whether we're trying to figure out the best diagnostic modality or what their mutational profile should look like, and if they need neoadjuvant therapy or they need trimodality therapy. And so as a surgeon, I love being part of a team, and that team is both inside the operating room and outside the operating room. So let's talk about early stage lung cancer. And I know that we're all providers, but one of the things that I think is really hard is our target keeps moving. So AJCC 8 changed a bunch of things for us. It's great for our patients because it lets us know with a little bit more definition who is truly early stage, and really helps us tailor kind of our survival based on a much more accurate and granular staging. The thumbnail is just stage 1 is all T1 lesions without nodal or metastatic involvement. T1B, stage 1B is going to be T2A without any lymph nodes, but well, let's not split hairs. Stage 2 is the one that's, I think, a little bit murkier. T1 lesions with N1 nodal involvement. T2 lesions, both with nodal N1 involvement, which will be our stage 2Bs, but also without nodal involvement, so they're stage 2As. And then we always have to remember that T3 without nodal involvement still is considered a stage 2B. So it can cover a pretty large swath of T stage. And with the most current guidelines, that's going to mean anything from, you know, in situ to, you know, we're going up with T3, it's going to go up to 7 centimeters. So there are lots of lesions that before would fall into a T4 category, and those have been downstage to T3 if there is no nodal involvement. So I just figured I would show you guys this. This is a little card that I pass out to our fellows so that they can keep it in their pocket when they're trying to figure out somebody's clinical stage or their pathologic stage. And what I did is I kind of highlighted our stage 1, 2, you know, 1A, 1 through 3, 1B, and then 2A and 2B. And although it looks really pretty in terms of the color coding, I like the fact that you can see what your T stage is, and then you go by your nodal stage, and where they intersect will tell you what you have in terms of your stage. And I think that what's really interesting is that I wish I had more patients who fell into these categories. Unfortunately, I have more patients who live between this red line and this light purple area, either clinically or at the time of surgical resection. So what I wanted to talk about is where do we stand right now in kind of the two, I kind of consider it the fork and knife of what can we do for local control. I'm not going to talk about systemic therapy. I'm just going to talk about local control. And the reason why I use the word local control is that surgical resection is local control. And then stereotactic body radiation therapy is our corollary for a purely non-invasive but local control modality to be able to deal with early stage lung cancer. Now, as you all know, surgical resection is still the gold standard. And that includes lobectomy and segmentectomy. And the reason why I put this in here is that it's important for us to understand that there is anatomic resection, which is really what I'm going to focus on in terms of the gold standard. For some of our patients, we can have lung-sparing non-anatomic resections. And there is data to indicate that non-anatomic wedge resections with a lymph node dissection are approaching equivalent local recurrence rates and overall survival as segmentectomy. But that data is a little bit murkier. In general, the more recent studies that have looked at surgical resection versus other modalities almost exclusively are going to be minimally invasive, whereas the data from the late 90s, early 2000s would have a mix of maybe a muscle-sparing thoracotomy versus a thoracoscopic approach. And many times with our patients and even with our referring physicians, I get questions about, does the minimally invasive approach matter? Is robotic better than thoracoscopic? And I kind of think it's apples and oranges. They're both fruit. Both of them are better than a thoracotomy or even a muscle-sparing thoracotomy. But whatever the surgeon is most comfortable with, the patient will usually have a similar length of stay and recovery. And both of them, whether you're doing it robotically assisted or thoracoscopic, lobectomy and segmentectomy give the surgeon the opportunity for mediastinal lymph node sampling, even in patients who have no clinical evidence of nodal involvement. And this, I think, is really key when we start talking about some of the work, the retrospective studies that have come out in the last 2 years, looking at head-to-head, how do we do? Now, stereotactic body radiation therapy, or SBRT, in the short term can be equivalent to lobectomy, primarily in patients who are not surgical candidates. And this is part of the challenge with a lot of the literature that's out there, that not every study has really had equivalent patients. And most patients who get SBRT are usually turned down for surgery for some medical reason, or less commonly because the patient prefers not to have surgery. And I'll get to that a little bit later when we're talking about a couple of studies I'd like to discuss. There's really minimal morbidity, very minimal inconvenience, minimal downtime, and they do get excellent local control in the short and intermediate term. So for the first 3 and in some studies up to 5 years, they may have equivalent local control, but I think it'd be nice to kind of look over time, once again, at a couple of studies that can look head to head to see how do people do and where does surgery really fall in the current era in comparison to SBRT. So this study actually was in the Annals of Thoracic Surgery within the last year, and it was looking at the survival. And that's really the big question that I get, in clinic from patients who are wanting to know all of their treatment options. And as part of my responsibility as a surgeon is to not be myopic. I need to let them know what all of their treatment options are, and then give my recommendation of whether or not I think they're a surgical candidate or not, so that they can understand. Because most of our patients who are coming in have surfed the internet, or they've had a family member, 15 years ago that had a big thoracotomy. They think I'm going to open them up like, a can of biscuits, and need to let them know that actually there are very different options. This was primarily looking at survival, and it's looking at early stage lung cancer, and this is stage 1 and 2, basically what we described earlier. That selection for SBRT was associated with the elderly, Black race, and lower T stage, and that there was an increase in the use of SBRT. And this study looked at, I think, 2006 to 2016. And in the last half of their study, they found a significant increase in the utilization of SBRT. Surgery was still associated with a higher median survival, almost double that of SBRT, and that was statistically significant. And that benefit persisted after Cox regression analysis, still with a hazard ratio of 1.6 with a p-value of 0.001. I actually was pretty surprised by this because one of the challenges that we have in this region oftentimes is having patients who are able to, who are healthy enough, and this goes back to lung cancer screening. Oftentimes we don't get early stage cancers, but when we do, they often have significant comorbidities that would either restrict them. The other piece that I find interesting, especially with certain ethnic groups, is a resistance to surgery overall. There's a lot of cultural beliefs around what surgery does to cancer that we as clinicians are really tasked with dismantling in order to help our patients understand what is the best option for them, and then contextualize it in what makes sense for them as individuals, so that they can understand the pathology that they are burdened with, but also the tools that are at their disposal to combat this cancer. And then the second study that I wanted to look at was just this one that talks about recurrence. So we talked about overall survival, but let's also talk about really the bigger issue, which is which one is better at dealing with local recurrence. And this was specifically looking at only lobectomy. This did not look at segmentectomy or wedge resection, which I think skewed some of the results. Also, this was a retrospective study. But they found that SBRT was associated with increased local recurrence, which makes sense if you're going to compare it to lobectomy. And also, which I found actually interesting, decreased overall survival. Now, granted, these were not as well matched as the previous study. This was a retrospective study, so there was some selection bias of those who would actually participate with SBRT over surgery. They're less healthy patients with more comorbidities. But also, it was associated with increased regional nodal recurrence, which goes back to kind of what I was talking about earlier, which part of the benefit of a surgical resection isn't just the resection itself, but I think it's also the nodal dissection. It helps us really truly get a very accurate pathologic stage of our patients at that moment in time, especially if they are stage 1. So it's more than just the biology of disease, but also to be able to get those micrometastases really well defined. And as somebody who routinely uses as many modalities as the OR will let me, so whether it's EVIS or navigational bronchoscopy, I use any tool that I have in my armamentarium to be able to help our patients and our treatment team figure out what we need to do for patients. And I absolutely am very supportive of our radiation oncology team, and whether it's CyberKnife or Linac-based SBRT, there are huge leaps forward in local control that for some of our patients, they would otherwise elect to not have any treatment whatsoever. And so what I would love for people to take away from this is not that SBRT is inferior, it's actually not. But I think what we need to remember that in the age of looking towards the most minimally invasive modalities, we must not lose sight of the fact that surgery still has a very significant role in survival for our patients with lung cancer. And when we have early stage patients, it is our chance at cure, and it's our chance at getting that 85% survival rate at 5 years. And I think it's something that maybe we take a little bit for granted, but I think it's something that I'd love to highlight because we can do it better than we were able to even 10 years ago. Lower length of stay, less comorbidities, less complications, return to work. And we're able to do it in higher risk patients. And so I think that our ability to support people and carry them through surgery has allowed us to care for more people. If we're able to identify early stage lung cancer patients, my recommendation is that although SBRT use has increased, because there is a lot of both we have patients who are very sick, but also we have patients who don't want to have downtime. And I think we need to contextualize all of the modalities in the context of what's going to be best for our patients. And then lastly, surgery still remains a gold standard and is associated with less local and regional recurrence and improved overall survival. And that's really what we're trying to get to. And we, as always, need to continue to hone our selection criteria and algorithms to identify who really benefits the most from SBRT, who has best quality of life, even if they may not have a longer overall survival. And then who can we really support best with a surgical intervention and making sure that we give every patient access to their best option at cure. So I'm going to be super short. And if people have any questions, you can ask me.
Awesome. Thank you, Dr. Oliver. Dr. Hagstrom, you can go ahead and start pulling up your slides, but I wanted to tell everyone that we are so excited to have Dr. Oliver on our board, and we are going to get her involved in many more things, so you will see her face more than just tonight. So we are excited. And Dr. Hagstrom, you can take it away.
All right, can everybody hear? I've got more slides, so I'm going to go as quickly, and hopefully you can go back and review. I appreciate the opportunity to go through the lung cancer update. I have made a little bit of a tweak to what was assigned to me. I was kind of looking in the last calendar year, what has changed. So I'm going to go through targeted therapy updates, immunotherapy updates, both for non-small cell lung cancer, and then at the end I'll have a small cell cancer update as well. I also feel that Jeff kind of stole a little bit of my thunder with his timeline. So I'm going to have to go back and fill in some of the holes that he had in there so I can explain. So first we'll start with the EGFR data. So mutations in EGFR tyrosine kinases are present in roughly 15% of lung adenocarcinomas in the United States and substantially higher in other populations globally. Early stage EGFR mutation patients following resection, pending their tumor characteristics, previously received systemic chemotherapy to decrease their risk of recurrence. Unfortunately, no prior EGFR TKI therapy had been shown a clear benefit in the adjuvant setting. Enter the ADORA data set that was published this past year. In this study, there were 682 patients that had stage 1 through 3 EGFR mutated non-small cell lung cancers, and they were randomized to osimertinib for 3 years or placebo. And at 24 months, 89% of the patients in the osimertinib group versus 52% of those in the placebo group were alive and disease-free. That's displayed in this initial figure on the right. And you can see in the top figure that these graphs, the lines separate relatively quickly at 6 months, and they stay separated for quite some time. With an overall hazard ratio of disease recurrence or death of 0.2, it strongly favors osimertinib in that patient population. That's displayed in the bottom hazard ratio curve. As you can see, it doesn't necessarily matter what stage or what actual EGFR mutation was present for their favorable outcome to be had by the patients that received osimertinib. We also know that osimertinib has good CNS penetration. At 24 months, 98% of the patients in the osimertinib group versus 85% of those in the placebo group were alive without CNS disease. So the overall hazard ratio for disease recurrence or death was 0.18. And same as the prior, the curves separate relatively early and stay separated, which is encouraging. Although the overall survival data is immature, the publication of this data set prompted the FDA to approve adjuvant osimertinib for a 3-year duration in patients with resected stage 1B and 3A non-small cell lung cancers harboring EGFR sensitizing mutations. Next, we'll talk about ROS1. ROS1 fusions are roughly 1% of non-small cell lung cancer mutations, and they're not very commonly seen. However, we are now starting to be able to detect these with the improvements in the more wide use of NGS. So entrectinib is a dual TRK ROS1 inhibitor, and previously the frontline therapy that for ROS1 fusions was crizotinib. So this likely will change based on the data from this publication that was released in JCO this past year. This was a pooled analysis of 3 phase 1 to 2 studies with 161 patients. And with the provision of entrectinib, which is an oral medication, the response rate was 67% with a 12-month duration of response of 63%. So good responses, durable responses, and with a PFS rate of 55%. The 12-month overall survival rate was 81%. And probably most importantly for this drug in comparison to crizotinib, there were 24 patients with measurable baseline CNS disease, and their response rate was 79.2% with intracranial response rate or duration of 12.9 months. So with CNS penetration greater than crizotinib, this drug is quickly moving into the front line, as it probably should. Next, we'll talk about KRAS. KRAS mutations are the most common mutations seen in non-small cell lung cancer. Unfortunately, KRAS mutations have long been a predictor of poor outcome, and they have not been successfully targeted with previous attempts. So this data set was published early in 2020, and then followed up with this last year for sotorasib. So this medication is a KRAS inhibitor. In this initial phase 1 study that was released, there were 129 patients. 59 of those patients had non-small cell lung cancer, and they all possessed a KRAS G12C mutation. For the lung cancer patients, there was a response rate of 88%, and that included complete and partial responses as well as stable disease. And 32% of those patients had confirmed objective responses. So very encouraging for a targeted medicine. The median PFS in the study was 6.3 months, and subsequently, a phase 2 study that was published just 2 months ago with only non-small cell lung cancer patients confirmed these findings and supported its use. Therefore, sotorasib has been approved as a breakthrough medication for patients with a KRAS G12C mutation. Now, it's important to note that this medication does not work for other mutations with KRAS, so we're still at the drawing board stage to some degree, trying to find a targeted therapy for those. Next, we'll talk about RET fusions. RET fusions are, again, around 1% of mutated non-small cell lung cancers. Prior to this year, there were not medications available specifically for RET fusion, so this is a pretty exciting turn. Initially, the Libretto 001 publication was in 2020. It was a phase 1/2 study in which there were 105 patients, 58 of those with non-small cell lung cancer. RET fusions are often also seen in thymic carcinomas. So the objective response rate in the untreated non-small cell lung cancer patient population was 85%, with 63% in patients that had previously received chemotherapy. Probably the most important figure from this study was a duration of response of 17.5 months, which is a very, very long time. And among the 11 patients that were non-small cell lung cancer patients, 11 of them had CNS measurable disease in which they had an objective intracranial response rate of 91%. So it's a very exciting drug that also looks at you can see this in the waterfall plot on the right, the patients that had responses which were decreasing tumor volume consuming with the downward bars. So it's much, a very, very excellent result. After this was released, pralsetinib actually was approved in June of this year, similarly for a study with only non-small cell lung cancer patients. And they had very, very similar response rates, as well as pralsetinib does cross the blood-brain barrier and has CNS activity. So in the span of a year, we had no medications, and now we have 2 quite effective ones. So HER3 has been identified as a resistance pathway in EGFR positive patients, and is notably overexpressed in up to 80% of resistant EGFR non-small cell lung cancer. Patritumab deruxtecan is a fully human anti-HER3 IgG1 monoclonal antibody, and it's linked to a topoisomerase inhibitor payload. So this data was released at the ASCO meeting, so it's hot off the presses. And it was part of the phase 1 study that was shown for resistant non-small cell lung cancer patients, in which this compound, which is an infusional compound, had an overall response rate of 39% with a PFS of 8.2 months. So in the cartoon in the bottom, the molecule is taken in by the HER3 receptor, internalized, and then the payload is cleaved. Then it does DNA damage, as chemotherapy does, to the EGFR resistant cancer cell. So the efficacy was seen in this study across multiple expressions of HER3, and there is now a phase 2 exploration, which we actually have just opened in Charlotte for this compound, so we're pretty excited about it. Next, we'll talk about immunotherapy for non-small cell lung cancer. there was an important update for a previous data set that should be kind of mentioned in this last year. The Pacific study was a study that was published initially in 2018, in which patients who received concurrent chemo XRT were randomized in a 2-to-1 fashion to receive durvalumab versus placebo. When it was initially published in 2018, the 24-month overall response rate was 66% in the durva arm versus 55.6%. And the PFS was 17.2 months versus 5.6. When this data was released, it was practiced and paradigm changing for the patients that could not undergo a curative resection. However, the overall survival data was immature. So enter this publication in the Journal of Thoracic Oncology this year, the updated overall survival with a hazard ratio of 0.71 and a PFS of 0.55. They remained consistent with their initial analysis, but the median overall survival for the durva arm was 47.5 months versus 29.1 months in the placebo arm. So it's an excellent result. The estimated 4-year overall survival was 49.6% versus 36.3%, and the 5-year survival was 42.9 versus 33.4. In prior kind of graphs and things, the importance with these comparative arms is that the curves separate relatively early and they stay separate, which they do in this particular instance. For PFS, very similar good results. For the 4-year PFS of 35.3 versus 19.5, and for 5-year 33.1 versus 19.0. So an estimated 42.9% of the patients that were randomized to the durvalumab arm were alive at 5 years. So this updated analysis from the Pacific study demonstrates not only sustained overall survival, but durable PFS, which is really important. This confirms efficacy and supports the use of consolidative durvalumab for chemo and radiation therapy. And lastly, I'll talk briefly about small cell. Initially, there was enthusiasm for both single agent and combination immunotherapy in extensive stage small cell. And unfortunately, pembrolizumab in combination with platinum and etoposide failed to meet overall survival endpoints in KEYNOTE-604. And therefore, pembrolizumab's indication for small cell was withdrawn this year. A similar fate was met by nivolumab when we were looking at the CheckMate 451 and 331 data. But that doesn't mean that immunotherapy does not have a role in small cell lung cancer. So this is the schema for IMpower 133, in which patients with extensive stage small cell were given carboplatin and etoposide and randomized to receive either atezolizumab or placebo. And this was initially published in 2018, and the survival and PD-L1 status was published in 2021. This actually represents the first major therapeutic advance in nearly 3 decades for extensive stage small cell lung cancer. And in this study, there were 403 patients. The immunotherapy patients received maintenance atezolizumab for up to 6 months duration. So at 23 months, the median overall survival compared to placebo was 12.3 versus 10.3 with a statistically significant difference, which is important. At 18 months, 34% were alive in the atezolizumab arm versus 21% in the chemotherapy alone arm. And the rates of toxicity of any grade, especially grade 3 or greater, were identical in these 2 arms. In the subset analysis, the PD-L1 IHC nor the blood-based tumor and mutational burden was shown to be a predictor of biomarker response. So in combination therapy now is the way we've moved into small cell, with platinum and etoposide either with atezolizumab or durvalumab as standards in patients without immunotherapy contraindications in the first-line setting. The durvalumab data set from Caspian was updated this year as well. The statistics were not run for statistical significance between the 2 different arms. However, there was a significant response that was seen, as well as the durable duration of responses was quite similar and encouraging as well. The PD-L1 status and tumor mutational burden are continue to not predict responses in small cell lung cancer. And lastly, there's pending the timing of failure for frontline therapy options for extensive stage small cell remain limited. Relapses within 6 months of the first line therapy remains a harbinger of poor outcome and decreased survival. Previously, combinations of immunotherapy versus camptothecin provision were considered outside of a clinical trial. And lurbinectedin as an alkylating agent received accelerated approval for provision and salvage for patients with resistant relapse. So this was from a publication in 2020, in which there were 105 patients who had previously progressed and received platinum-based chemotherapy. The overall response rate for lurbinectedin was 33%, with a median duration of 5.1 months. 25% of those responses were actually durable and exceeding 6 months, which is very, very good for this disease state. In the resistant relapse population, when the chemo-free interval was less than 90 days, the overall response rate was 22%, with a PFS of 2.6 months and an overall survival of 5 months. For patients with sensitive relapse, the overall response rate was 45%, with a PFS of 4.5 months and overall survival of 11.9 months. So comparative to previous topotecan therapy, this represents a significant response improvement for this patient population. So in conclusion, for non-small cell, osimertinib should be provided in patients with resected stage 1B and 3A non-small cell lung cancer with EGFR sensitizing mutations. I think this also kind of harkens back to Andrea's talk as well, because we need to be testing patients with resected adenocarcinomas at these early stages to find more of these patients that can derive this benefit. Expanding targeted options for patients with RET, ROS1, and KRAS mutations also can highlight the continued importance of NGS for patients with non-small cell lung cancer. And the updated PACIFIC data set confirms the overall survival benefit for the use of maintenance durvalumab and atezolizumab, in unresectable non-small cell lung cancer. In the small cell space, unfortunately, KEYNOTE-604 and the CheckMate studies have kind of changed how we give these drugs in sequence for nivolumab and pembrolizumab. However, giving them in the frontline setting without a contraindication is now the evolving standard of care, especially with durvalumab and atezolizumab from the data from IMpower 133 and Caspian that was released this past year. And lurbinectedin is an effective, well-tolerated agent in salvage following failure of first-line therapy. And I think that's all I have.
Great, thank you. Dr. Paco, if you want to go ahead and load up your slides.
Will do. QC is okay? All right, well, thanks very much for having me. Hope most of you guys are still on, and Dr. Hagstrom, you made my job much easier. I will request to go after you always from here on. I really appreciate that. So I actually was really hoping to not have to talk much about therapy and I could talk about biomarkers, which I think this was my first time ever talking about biomarkers only. So here's my disclosures. I don't think it will affect much what I have to say. So really when it comes to biomarkers, I think of basically two kinds. The first biomarker, which is what most people are probably thinking about for this talk, essentially is a predictive biomarker, which essentially speaks to the idea of, does this biomarker predict whether a therapy will work? The second type of biomarker is a prognostic one. So the biomarker essentially tells us what is the likelihood of a patient doing well or poorly based on the biomarker. But the reality is pretty much every single biomarker in lung cancer is both. And I'll explain some of that as I go. And I think actually not only the biomarker is very predictive, but they also make it very hard to prognosticate in lung cancer. When I started at UNC 8 years ago, I actually think it was actually fairly easy to prognosticate for most of my patients. Now I would probably argue lung cancer is the hardest cancer to prognosticate for. And so often my patients want to know what's their prognosis. And even if they're fully staged, I can't always answer that because I really, really need to know what kind of lung cancer they have. And so I feel like the job I have tonight is to really drill down to what kinds of lung cancers are there. I know this is recorded, but I will say the way I view lung cancer is there's probably at least 1,000 types of lung cancer. Without enough time, I can't really articulate what that means. So tonight, suffice to say, I'm only going to talk about maybe 20, maybe 30 tonight. But in a lot of ways, I think, and if I had time and maybe another talk, I could talk about what I think the future looks like in terms of biomarkers and lung cancer. And I do think it'll actually become much more complex than it already is, which is actually a lot of fun. So maybe 10, 15 years ago, this is kind of how we thought of lung cancer. We do think of lung adenocarcinoma, squamous cell carcinoma in general. That makes up about 85% of all lung cancer. Large cell lung cancer is one we don't talk much about. That's become more nuanced and split more into subsets of adeno. And then small cell was just spoken about. For tonight, most of what I'm going to talk about is adenocarcinoma, although I will sneak in some information on squamous cell carcinoma. So as I mentioned, most of lung cancer is made up by these two subtypes, adenocarcinoma and squamous. For sake of time, I won't talk much about how adeno is more common now. In the past, squamous was actually much more common. We actually think that has a lot more to do with filtered cigarettes and pushing the carcinogens deeper into the lungs, which is where these adenocarcinomas form. And then when it comes to subsets, so now you're looking at different slices of pie. And so I would call these are different kinds of lung adenocarcinoma. And you see these little stars. I'm not going to talk much about these subsets tonight. So ALK, BRAF, ROS, EGFR. Fortunately, as already mentioned, the treatment of those has been covered, but these are really important subsets. I'm about to show you why. Now, in squamous cell carcinoma, there are these different slices of pie, and I'm about to talk about why none of these are probably really relevant. In oncology, a simple rule of thumb is a slice of pie, as you're seeing here, in terms of a biomarker, is really only relevant for two reasons, predictive and prognosis. In terms of predictive, it's only relevant if there's a therapy for it. So we've known that KRAS mutant lung cancer for the longest time is an important driver of the disease, but we have never until recently had a drug for it. Now it's predictive of response. And I'll articulate a little bit more about that later. But this is what's really important to me is if you can actually identify a subset, and these are the ones I'm talking about now, ALK, BRAF, ROS, and EGFR, and put them on a therapy that hits that, it changes outcome, it changes response, and it actually changes prognosis. And so this is one of the most important studies, in my opinion, of targeted therapeutics. It's now been published 7 years in JAMA, but it actually shows you actually double survival when you put a patient with one of these subtypes. These four I've highlighted were included in this study, when you put them on a targeted therapy. So if you put a BRAF mutant lung cancer patient on a BRAF inhibitor or a combination BRAF-MEK inhibitor, you can literally double their survival and so forth. ALK inhibitors, ROS inhibitors, EGFR inhibitors. And this is true across the board. In fact, we definitely know RET inhibitors have tremendous activity, which I'll comment on. KRAS inhibitors will hopefully lead to improved survival. It's still early days, but it's very exciting. This is not transpired in squamous cell carcinoma. Is that showing up on your screen? So squamous cell carcinoma, unfortunately, despite many attempts to drug and create drugs for these different putative drivers, has not really resulted in response. So far, even though we can identify these mutations in lung squamous carcinoma, we do not regard them as important drivers. And unfortunately, they don't predict outcome. And so I do not regard these as true biomarkers, whether they're predictive or prognostic in squamous. And I think squamous in the end is going to be a very different type of tumor than lung adeno. I think that's bearing out a lot over the past decade. So this is now more of an era that we're moving into. So I'm only going to really cover the ones I have an asterisk by, because this is a newer era in the past maybe 8 months. And as has been mentioned essentially several times now, it's a very exciting time to be a lung cancer doc, because it's super hard to be a lung cancer doc. There's so much going on, so much to keep up with. I actually find that really fun and exciting. And I think it's only going to get better, meaning it's going to be more difficult to keep up with. And so all of these slices of pie I would regard as biomarkers. If we can eventually pair medicines to all of them, we will lead to better responses, and I certainly think we'll see better prognoses. And so essentially, in the lung medical oncology world, you really have to be able to memorize all of this, and you better memorize it fast because there's more coming. This just speaks to the amount of approvals we had. So it was actually kind of easy to be a lung cancer doc about 10 years ago. 10 years ago, this is the kind of approval pace that you're looking at, maybe a couple approvals every other year. Now we're seeing numerous approvals every single year. This is actually outdated. This came up to the end of 2020. You can see we had quite a few approvals in the past year and a half. And then ever since then, we've seen more. So since 2020 up to current, there's been several more targeting RET, MET. There's now, this is actually already outdated. I updated this slide a few months ago and it's already outdated. So sotorasib, FDA approved, adagrasib, also FDA approved in KRAS G12C mutant disease. So it's really exciting. I love how hard this is to keep up with because we're talking about one type of disease in the chest. So this is the most recent updated guidelines in NCCN. I'm only talking tonight about KRAS, MET, and RETs because some of the other ones are almost old news, but all of these are biomarkers. EGFR mutant, there's all kinds of flavors of EGFR mutations now. For sake of time, I can't talk about all of them. NTRK, BRAF, ROS, ALK, it's really exciting. KRAS G12C, MET, RET, and there's more coming. I will get to immunotherapy at the end, but what's really critical, and I'll just emphasize this a couple times throughout my talk, is knowing what kind of lung cancer you have. You cannot anymore say I have lung adenocarcinoma. You have to be able to say I have EGFR mutant lung adenocarcinoma or KRAS mutant lung adenocarcinoma. So until you know that, you are getting third world medicine care. It is my opinion that it's malpractice not to know what molecular subset of lung adenocarcinoma you have. And so if a patient comes to me and they do not know, that means they've essentially had a disservice and they've not had molecular testing. You essentially have to know what kind of molecular driver you have because of how much of a difference it makes in their care. So I'm going to just cover a few of these fairly quickly. So this KRAS, we've known for a long time that almost a third of lung adenocarcinoma is driven by KRAS mutations. One of the most common ones of these KRAS mutations is called G12C. And it took about literally 40 years to be able to develop drugs that directly hit this. There are two, sotorasib and adagrasib. One's made by Amgen and one's made by Mirati. They're both fantastic and highly potent, and they work quite well. That's pretty much already been covered, so I'm going to skip that. I'm going to show a lot of waterfall plots. This is a common plot we look at for medical oncologists, but I know we have a lot of different people in the audience tonight. Essentially, you can just picture a patient's tumor and how much the tumor shrinks based on the percentage you're seeing here. So really, you know, the patient, when they start a therapy, they want to see their tumor shrink completely. And so you can see a patient over here had almost complete shrinkage of their tumor. And obviously, the deeper the waterfall, the higher the percent of patients having an amazing response. And you can see these patients over here, the tumors really didn't shrink much, but at least they were stable. So at least when you're going on a therapy, especially at the stage these patients are at, you really want your tumors to be at least controlled, if not shrink. And I'll come back to the importance of the tumor shrinking soon. I figured I'd sprinkle in different things in my talk for everyone. So this may be actually fair for anyone in the audience to say, we'll see if they're familiar with this. So this is a kinome tree. I don't think a lot of medical oncologists even know and can articulate what's going on in a kinome tree. But what I'm showing you on the left is a phylogeny of the kinome in the entire human body. So there are about 580, I believe, or 600 kinases in the body. These are all critically important for normal function and homeostasis in the body in many different tissues. The most actually, is the GI tract, the skin, certainly the heart, kidneys, liver. So these are really important organs and functions for these kinases to operate. Turns out many cancers have mutations in these. And so over the years, people have tried to develop drugs that hit these. I'm going to point out a couple of dirty drugs. So we normally think of these pills being targeted therapies and chemo being more crude and toxic. Well, I'm going to explain why that's not always true. So pills such as sunitinib, it's kind of an old school tyrosine kinase inhibitor, one of the newer ones, thought to be a VEGF inhibitor, but I got news for you, it inhibits just about everything. So where you see the dot that's in red, the bigger the dot, the more potent it inhibits that kinase. And I should just point out these, this kinome tree is what you're seeing over here. These are all different kinome trees. But this, you can see this drug is essentially hitting every single kinase in the human body. So you better believe that when patients take sunitinib, they get pretty sick. Probably one of the worst tyrosine kinase inhibitors is dasatinib. There's a lot of toxicity associated with this. You can see that it really hits. There's big red circles in a lot of these patients. or I'm sorry, a lot of these kinases, and that will lead to a lot of toxicity. And so what I'm trying to really hone in on is the idea of newer drugs, which I'm about to show you. Essentially what you want is a very potent drug that hits one kinase, the one kinase that's the problem. If you want to put your finger in the dam, it's basically just clogging up that one hole in the dam instead of trying to put, paste over the entire dam. That's essentially what's going on here with dasatinib. It's just trying to put cement over the entire dam. This is just putting your finger in the dam. This essentially will lead to a tumor shrinking and hopefully very little toxicity. And so I'm going to talk about how some of these newer drugs are much cleaner, much more potent against the targets we're trying to hit. So these two drugs for MET. So again, you have to be able to look for MET either exon 14 mutations or MET copy number gain, which I'm going to talk about soon. But these two new drugs that got approval, tepotinib and capatinib, are incredibly potent. These are sub-nanomolar dose potency. So what's amazing is not only are they incredibly potent, they're incredibly clean. They're really only hitting MET. So there's a lot of reason to be excited about being able to use these medicines. They should really hit the target quite potently and spare a lot of toxicity. And of course, the key is finding this problem. If a patient has a MET mutation or copy number gain, it's very satisfying. And it feels really good because these patients really can get on some great medicines. Some more waterfall plots. Again, you can start seeing what we call deep waterfall plots, where most patients are seeing nice responses and deep responses, where these tumors are really shrinking down. It's really fun to be able to see this. One thing I'll point out is copy number gain. So a lot of reports may say something like MET amplification. So one thing I really want to encourage anyone that's getting these molecular reports to ask about is how many copies. I'll give an anecdotal case. I have a lady where I sent her tumor off to Foundation Medicine. It's a pretty common company where we'll get molecular analysis. The report came back showing maybe 10 different things were wrong, one of which was a MET amplification. You can usually ask these companies, well, how many copies of the gain do you see? And this patient had been through pretty much every line of therapy. We had pretty much nothing else to give her. And they told me that she had 28 copies of MET. I put her on crizotinib, and that was 1.5 years ago. She's had a beautiful response and is still on crizotinib. And like I already pointed out, there's other MET inhibitors that are even better and cleaner that I'll be able to move her to once she progresses. And so I think it's really exciting and important to know the number of copies of MET amplification your patient has. RET biology has been covered some. The depth of response I'm about to cover, and that's already been shown. But I just want to point out again this kinome tree. These drugs, selpercatinib and pralsetinib, are very, very exciting, again, for a few reasons. One, the potency is very, very high. The lower the number, the better. So these are very, very potent drugs, but in particular, what's exciting is not only are they potent, they really hit what you want to hit. You can see there's not a lot of other dots. They're really just hitting what you're going after, which is RET. And so that means the tumor should respond. It should respond with a very potent inhibitor without it leading to a lot of toxicity in the body. And that's essentially what we're seeing, that the drugs are usually very well tolerated and they lead to a really nice response. I honestly would have never thought 8 years ago, when I started taking care of lung cancer patients full time, I would see waterfall plots that look like this. I mean, this is stunning to see this % of patients having dramatic responses. But I just can't emphasize enough, this is 2% of lung adenocarcinoma. You have to find it. And unfortunately, people in the community often will send biomarker type tests to companies that are only looking for maybe 10 genes. You really need to be able to send it off to companies that I think are looking for 300 or 400 abnormalities, and really have the ability to find these kind of abnormalities. And so these things just can't be missed. Patients unfortunately have RET mutations or RET fusions that are not being picked up, and they're not having the benefit of these kind of therapies. So I'm going to try and briefly cover immune therapy. That's almost impossible, so I'm really grateful for Dr. Hagstrom for covering it already. But it is a biomarker, and it's incredibly important. And so this is where squamous comes into play too. So adenocarcinoma and squamous carcinoma patients benefit from this. I just want to actually show PD-L1. So we talk a lot about the number, but I just want to show what it looks like. So this is a tumor biopsy. PD-L1 is just a protein. So everything you see that's in brown is actually highlighting PD-L1. This is probably close to 100% PD-L1 expression. You can see that almost all the cancer cells in this specimen have a lot of brown staining. So that's high PD-L1. Whenever you see this in clinic, if I see a patient that's new and they have a high PD-L1, it's very exciting. I'm about to show you why. So one thing I did want to show is immune therapy actually happening. I could show you cartoons and stuff, but I think it's actually neat to be able to watch it in action. So hopefully this will work. The first thing I'm going to do is tee it up. So the next video essentially is showing it working, but let me tee it up for you so you can actually see the difference. What I want you to look at here on the left side is essentially a tumor that we call hot. The red cells are the immune cells, the T cells, and the green cells are the cancer cells. This is essentially what we think of as a tumor that has high PD-L1 that's likely to respond to immune therapy. And it just essentially wants you to observe that the red cells are going to town. They're busy. They're clearly trying to do something in that tumor. On the right is what we would call a cold tumor. This is essentially a low PD-L1 tumor that's likely not to benefit with immune therapy. So hopefully when this video launches, it's going to be pretty evident. You can see on the left, a lot of red cells kind of moving around. They're trying to chew on the cancer cells that are green. On the right, you can see there's only a couple immune cells and they're kind of stagnant, not doing very much. Well, that's what's exciting if you can identify patients that'll have that benefit. If the immune cells can go to town and do what they're supposed to do. Here's the power of how fast immune therapy can work. On the left are these same red cells actively killing cancer cells. This is only 2 days. So it's 48 hours is what they can do in 2 days. And on the right, you're going to see what they can be doing in just 5 days. Hopefully, if I can get it to play. Oop. Let's see if I can get this to play. Pretty impressive, huh? If you don't see green cells on the right, it's because there aren't any. And this is a mouse model, but essentially is demonstrating how rapid immune cells can go to town and work. I just want to show again as a biomarker that immune therapy can be quite powerful. This is a trial that came out 5 years ago, essentially literally selecting patients that have PD-L1 where at least 50% of the tumor stains high. And this is looking at lung adenocarcinoma and lung squamous cell carcinoma and compared it to chemotherapy. And again, another statement I don't think I'd ever had made before is that something like immune therapy would actually be better than chemotherapy in the frontline setting. And it clearly won handedly. And what's even more exciting is the updated data here that came out this year in JCO. And this is looking at the 5-year survival of these patients on the same trial. So it's actually really remarkable seeing that in metastatic lung cancer, 5 years out, almost a third of patients are still alive. This is really a dramatic improvement compared to what things used to be in the case, 5-10 years ago. And I have many of my colleagues who treat other cancers where we are treating the same patient, but they actually have 2 different cancers at once. And when they see that the patient has lung cancer, they'll often tell me, well, I guess my cancer may not be as important to treat because they have lung cancer. And I usually tell them, I would not bet that. You better take good care of that cancer because our lung cancer patient may do quite well and may live 5-10 years, even with metastatic disease. It's taken a while for even our specialists in other cancers to be able to start catching up and realizing these patients are doing much better than they would have ever realized or ever thought. I did want to show this bit of data because it's really interesting. It came out a year ago. It's actually a combination of melanoma, kidney cancer, and lung cancer for patients that got nivolumab, another PD-1 antibody inhibitor. This is actually a really important point. It's a neat plot because it's a little bit different of a waterfall plot. Well, it's actually plotting in colors based on survival. So you can see essentially the 3, 4, and 5-year survival. So you can look at really focus on the orange and the green in this case. It's plotting it according to how much the tumors, when you kind of sum all the tumors together, how much the tumors shrink. A lot of people seem to think that immune therapy patients, as long as the tumors are controlled, they will live a long time. But actually what this data shows is that's not quite the case. If you look at the patients that get at least about 25% response, if you added all the tumors together and looked at what percent of the tumors shrink on immune therapy, if you get about 25% response, those are the patients that really are going on to live at least 4 to 5 years. And so I think this data is pretty unambiguous that if you're getting a response of about 25%, those are the patients you could almost have quite a bit of confidence actually that they're going to live at least 4 to 5 years. So I actually find that a pretty interesting biomarker in itself, that the depth of response to immune therapy may very well predict how long they live. It also speaks to the importance of recognizing that, you know, if they don't have much response or they even have a little bit of progression, it may not, I think sometimes we do try to hold on to immune therapy and its promise a little bit more than maybe realistic. Although I will say with the caveat that you can see some patients even had a little bit of progression, such as this patient, and they went on to live 4 years. These few patients that had a little bit of progression went on to live 5 years. So we still have a lot more work to do to understand this phenomena. But in general, if you see a response, you can also have a lot of confidence that's going to be durable. It's going to last a good while. And that's actually really exciting to me. How much time do I have? Do I need to stop here?
Yeah, go ahead whenever you're ready.
All right, I got a few more slides. And so this is just a simple concept I want to convey, that basically lung adeno and lung squamous and small cell are highly mutated cancers. They're amongst the most highly mutated cancers. This speaks to this concept of tumor mutational burden, so TMB. I just want to throw this in at the very end. I didn't plan on touching this one. It's a really complex topic as a biomarker, so I just figured I'd throw in a little thing about 10-foot poles. So this is where I'm getting my 10-foot pole. I'm not touching this one. I do think TMB is a bit controversial. We already know that lung cancers are highly mutated. The patients that tend to not benefit from immune therapy tend to have very low mutational burden. Those are also the patients that have oncogene-driven disease, such as ALK and EGFR and ROS. So I think that the TMB is essentially measuring some of the same things we already know about. I think that's my last slide. This is just a summary slide. Are we distributing the slides?
We are. We'll share the video.
Okay, good. All right. So I'll just really quickly summarize then that, you know, there are many predictive biomarkers which are in turn prognostic. You just have to look for them. We just got to look for them and look broad. Make sure that whatever you're sending your tumor out for to test for, it includes all the ones that have NCCN approved drugs. So there's a lot of NCCN approvals. Very exciting time. There's at least a couple highly potent, life-changing drugs for each of these. And RNA and DNA based next-gen sequencing is probably the way to go. I didn't have time to cover plasma cell-free DNA, but it's certainly another avenue to pursue and a very exciting time to look at that. Thanks very much for your time.
Awesome. Right. Thank you so much. Oh, and Dr. Ruiz, I'm going to call on one more person just real quick because we're missing one perspective here, and that's the radiation oncologist perspective. So Dr. Charles Shelton, if you're here, would you like to give a quick update from your side of the lung cancer field?
Hey, yeah, this is Trey Shelton from the Outer Banks. Can you guys hear me okay?
Yeah, awesome. Thanks for joining.
Great. Hey, can I show some slides real quick? I didn't expect to have slides, but I can share.
Yeah. Go ahead and show your face too, if you can.
Okay, yeah, let me turn on my monitor here. Hold on a second. If I can get this to work, you guys, hold on. Oh, shucks, I'm having IT problems. But so let me just kind of review what I was going to talk about without showing the slides. So, you know, we didn't hit a lot of the radiotherapy aspects today with advances or at least updates in radiation therapy. And while they're nowhere near as advanced as what you guys have been talking about with biomarkers and with some surgical techniques and some other things, I just want to highlight some of the things we're doing from a community perspective. So I'm a radiation oncologist in the community where there's a barrier to care. I've seen it because I'm about as far out as you can get on a barrier island in the Outer Banks of North Carolina. And so if there's a barrier, we've seen it. And as you guys have mentioned, we've seen a real shift in the paradigm of how we treat this cancer to one that's a totally patient-centered approach, where the decisions and the quality measures that we use are really driven by the patient's unique specific needs. And parallel with that, we've seen a dramatic technology-driven revolution as well that's taking place, not just in the the genomics of this cancer, but also in the innovative technologies that we're using to deliver the various treatments as well. So I wanted to highlight some of those. We've had improvements and advances in the radiotherapy planning that I just want to highlight a few of these. A lot of these are actually even available rurally, which is nice. So for example, the use of better diagnostic quality imaging that we can fuse with radiotherapy planning, which includes CT PET and MRI in the planning for delineation of tumor volumes, is now routinely used in over 95% of curative cases. That allows us as radiation doctors to escalate the dose of radiotherapy with both better precision and better treatment of involved sites of disease. We have added software that allows us to do what we call Deformable Co-Registration, which means we can use any diagnostic image done, for example, at UNC or at Duke, East Carolina. We can couple those images with our treatment planning sets to essentially help plan the tumor volume that we're going to treat, and also to help minimize doses to the normal to the normal organs that are in the vicinity of the tumor. So that's a big improvement, I think, in the radiotherapy planning. We also have motion assessment that we can use in our scans for lung cancer, which helps with thoracic treatment planning. We have, as you guys know, standardized dose constraints that are now part of the NCCN guidelines version 5, 2021, which really outlines the metrics that we have to meet when we're doing things like the stereotactic body radiotherapy that Dr. Oliver alluded to. We also have, interestingly, some artificial intelligence programs, which are now helping us to contour normal structures in the planning process, which really reduces the time to complete the treatment planning. And it also improves consistency between the various planners in radiation therapy, which is really, really nice to see. We also have advances in the delivery of radiation therapy. We have, for example, image-guided radiotherapy, which is routine in all of our practices. An example of that is the daily cone beam CT images that we get when we treat lung cancers that facilitate both the daily alignment of patients and their tumors. And it also allows us to measure the tumor response during the course of radiotherapy to see how the therapy is progressing. We also use motion management during the therapy, which is typically used for lung cancer. That includes things like respiratory gating, breath holding techniques, 4-dimensional radiotherapy, those types of things that you hear about quite often. In the community, what's helped us a lot is we've really shifted from 3D conformal therapy, which is kind of the outdated silver standard, to the gold standard, which is really IMRT with Linux, which allows us to really precisely conform the dose of the radiation while also reducing toxicity. And that benefit improves what we call the therapeutic index. We also have evolving technology with adaptive radiotherapy, where we're able to measure the changes in the delivery based on the tumor regression, and also measure dose absorption in the tumor, which can then be used to change the following subsequent therapy. And as Dr. Oliver mentioned, also stereotactic ablative radiotherapy or stereotactic body radiotherapy is, of course, being increasingly used in this disease, both in the primary management and in the setting of oligometastatic disease. So where we're seeing a lot of the changes in this field, I think from our standpoint are the increasing indications for radiotherapy, thanks to immunotherapy and the other targeted therapies. For example, radiotherapy certainly can synergize with immunotherapy without increasing toxicity, especially in the PD-L1 inhibitors. In addition, we're seeing the increased use of curative doses of radiotherapy in the setting of oligometastatic disease, something none of us would have contemplated a decade ago. And this, of course, is coming due to the longer survivals from the immunotherapy and the combinations, which may also help overcome some of the occurrence of the immune therapy mediated resistance. And lastly, there are patients surviving their primary lung cancer to experience second cancers, where we now have the technology to retreat patients in areas where it's in proximity to previous cancers. And one area that I really want to brag about with you guys, because almost everybody here except for me is from an academic powerhouse. One of the biggest programmatic changes that I've seen rurally is our ability to collaborate and share resources. And this, of course, is important in areas like us. We're a critical access hospital, and we do not have a thoracic surgeon. We do not have a thoracic medical oncologist. We do not have those degrees of specialty training. And by coordinating specialty care for lung cancer between academic cancer centers and centers or centers of high volume and community centers, we're able to really, I think, raise the bar in what we're delivering locally in our communities. An example that I can think of locally is our coordination with East Carolina. Of course, East Carolina is our flagship in the 29 county area of Eastern North Carolina. we typically do combined tumor boards where we can call in on given days of the week and present cases to help improve access to care with technologies and experts that we never would really be able to have locally. That includes Gamma Knife, for example, for brain mets, SBRT for early lung cancer, or even treatment of metastatic disease with methods we don't offer locally. And lastly, I'd like to mention the example of a kind of a neat peer-to-peer review process that we started in Eastern North Carolina about 8 years ago in 2013. We review every radiotherapy case in our region as a consensus group with East Carolina to ensure that the dose delivery, the methods used, the contours done, the organs at risk, the fractionation patterns, the combination of chemoradiotherapy and immunotherapy and targeted therapies are all synchronized in a way that's consistent with evidence-based guidelines within the region and with NCCN standards. And that's really, truly helped customize our care for our patients, I think, at least in rural Eastern North Carolina, and has helped improve their care as well. And that's it.
All right. Well, thank you for that, Dr. Shelton. My name is Jimmy Ruiz. I'm going to be the moderator for our discussion, and I'm going to be respectful to everyone's time today. We are going to adjourn at